So welcome back to Taking Charge of My Cancer podcast, episode 41. And I have a very special guest today, Dr. Lisa Chacko. So Dr. Chacko is a primary care physician, menopause specialist, and a medical educator. She owns a private practice in Florida focused on menopause and midlife health. She's a residency faculty at UCF and serves on the education committee of the Menopause Society. So Dr. Chacko, thank you so much for being here with me today. And I'm so excited about this podcast because I think it's going to really not only help the listeners, but myself. So great.
Thank you for inviting me.
Absolutely. Absolutely. So let's start out with, you want to tell us about your business and your mission?
Sure. My practice, I started it in part because I wanted to create a professional home for myself. As you probably know, a lot of physicians struggle working in the healthcare system, the conditions and being forced to go so fast. So, I would say the mission of the practice is partly for me and partly for my patients. For me, it gives me a space where I have control and autonomy and can practice the way that I want. And for my patients, I think similarly, it's a place where they can experience a slower pace of medicine, hopefully have very trusted source of information. I focus on women 40 and over, but I have patients who are certainly younger because, as your audience knows, people can go through menopause at all kinds of ages for all different reasons. So yeah, I sometimes joke it's like an artist studio. It doesn't feel like a doctor's office. We go slow, we take our time, and I really like for my patients to have sort of a narrative process with me.
That's great. It is amazing, and I'm so glad that physicians start to become into that mindset, because it is just so hard to see how our healthcare is just being driven by the insurance company and they dictaminating what we need to do, right? So you have to see so many patients and you have to be so productive and you need to do, and then it's just become a factory versus just really taking the time and listen to the patient, because I think this is what all of us went into healthcare for, right? To be able to really help patients and educate people. And it is just hard to do that sometimes in in general hospitals and different areas. So I'm so glad you're doing that.
Well, I'm glad that you agree. We could have a whole nother interview just about that, but I feel that doctors are in trouble and our labor is often exploited. So this is my little, rebellion.
Did you always plan on doing this?
I did not always plan to focus on menopause, no. But within healthcare, I have a degree in public health. I'm a primary care doctor. I always think about health through populations, through groups of people and what their needs are. And I've always been attracted to sort of spaces in medicine that are complicated or intersectional, like end-of-life care. So menopause kind of came through, there's a funny story how I got specifically into menopause, but I like it because it's a defined population of people. I can think a lot about their needs and design around that. And it's a niche of primary care. So I'm not being a primary care doctor, but I'm very focused. So yeah, and I think I always knew I wanted to own my own practice of medicine. But I didn't know it would be like this. So yes and no.
Okay, got you. So if we start talking about menopause, so something that really surprised me was, you hear about, just from the PT standpoint and from just a woman standpoint who is over the 50s, that's who I am, is kind of like, I always thought, the hot flashes, that's kind of what everybody complained about being bothered by. And really blow my mind were like about 2 years ago when we were sitting in one of the women's health fair over the Hilton here that UF organized, and listened to one of the gynecologists talking about menopause. That blow my mind how is the hot flashes is the minimum, is how many changes happen on your brain, your everything. I'm like, your bones, your health. And I was like, holy cow, this is like, it's not about the hot flashes anymore. This is really something that people need to know, that you better start doing something about these things, either with, natural ways or hormone supplements or whatever happens. But is not really, that really kind of like checked me. And that's when I was like, I need to start looking into really have some ways of kind of really get that in myself, because I don't want my brain and my body to deteriorate for this, that yes, I can, that is.
Yeah, well, we have to be cautious, right? Because for women who go through menopause, quote unquote, naturally, kind of at the average age, it's not a disease. We don't want to pathologize something that's in theory natural, but when you look at the science of it, it is so compelling and it is so complex. The physiology of menopause is part of why I got interested in this, and it does impact women's longevity and the health of their whole body. But I think separate from that are probably some of the people who listen to your podcast, which are cancer survivors. People can go through menopause early because of medications they take, hormone blockers, chemotherapy, surgery, all kinds of reasons. And that is a distinct conversation, and those patients need great access to care and a lot of information. So a lot of people feel the way you feel when they first start thinking about it, which is a little bit overwhelmed and a little bit fearful, like, wait a minute, am I not doing things right? Yeah. Which is part of why I like the work, because it's like, let's take a deep breath. Let me give you all the information. Let's make decisions together. I would just direct cancer survivors who, not in every case, but in many cases, would not take estrogen therapy to menopause.org, which is the website of our National Menopause Society. And they just released a position statement, and the official PDF, you can get it for free online, on non-hormonal treatments for hot flashes and symptoms of menopause. So I do want to just plug that report so people can access good information.
Great. That's super beneficial, because again, day in and day out, I keep hearing that a lot of complaints with symptoms on that. So I will start passing that information. Thank you for that. But give us your most painful lesson that you have learned on this journey.
I'll give a little context first, which is patients who work with me or people who know me know that as a physician and just as a person, I really believe that health is not just in your body, it's in your mind, it's in your emotions, it's the biopsychosocial approach. So my answer is in the psychologic realm, and I attribute the lesson to my good therapist, which is the most painful lesson is that pain is the lesson very often, and that the work is to tolerate the discomfort sometimes that we feel, and that actually trying to escape from your emotions can make them stronger. But sometimes just the ability to feel your emotions and feel uncomfortable is what makes you realize how strong you are. So my most painful lesson is actually the lesson to learn how to experience pain.
Wow, that's very, what did you learn from that?
It can take you anywhere, right? So, I mean, a lot of times people are feeling uneasy, they might feel anxious, they might feel stuck. I mean, you're feeling things that are not comfortable for you. And then perhaps you label that as like, that's bad. I don't want to feel uncomfortable. I want to watch Netflix. I want to have a beer. There's so many ways to escape that. So it's not, I don't believe that we all need to suffer. I believe go get help, get support. But sometimes, the willingness to feel that might be what's needed to help you realize, oh, I want to leave the job, or I want to take the risk, or, turn that suffering into something real rather than maybe just a neurosis.
Okay. That's awesome. I think I have seen it from that standpoint. That's very good.
Yeah.
How can people find you?
If they want to schedule an appointment, they can do that online through the practice website, which is just my name, md.com. So lisachackomd.com. There is also an Instagram page. It's not very active, but certainly if there's a class or an event or a collaboration or something, it would be posted there. And that's also just Lisa Chacko MD. I think those are the two main places. If you leave your email on the website, you will get periodic updates. So if we offer a new service or something, you would find out about that. So those three ways if you want to.
Perfect. And I'll make sure that I put it on the notes for the podcast so people can find you. Is there any books that you will recommend for the audience, and why?
I would recommend a particular author named Victoria Sweet. She's a doctor, so Victoria Sweet MD, and she wrote two excellent books, which I kind of always have to recommend as one recommendation. One is called Slow Medicine, and the other is called House of God. And if you're in medicine, if you're a med student or resident, a doctor, you work in hospitals, you work in healthcare, her writing is incredible. She's a physician who went back and got a degree in anthropology, and she's just able to tell stories and look at healthcare. And this slow medicine concept, in some ways I embrace in my practice, which is the idea that doctors need time to think, that we have to have space essentially to live like a more intellectual life where we can think and reflect, because that's how it used to be. And that often you can come to diagnosis and help people more in that way. So Victoria Sweet, that's who I'd recommend.
Okay, great. And then how about podcast?
Podcasts are tricky because there's so many, as you know. So obviously you want to like the host and you want to like the guests. I like a guy named Rich Roll. He's a health enthusiast. He's smart, he's likable, and he has a huge variety of guests, from doctors to Hollywood people to athletes to anybody. So I like him, Rich Roll.
Okay, perfect. And what's it? And one question you wish I would have asked you, and what will be your answer?
Well, I wish you would ask me about this study that was just published November 2nd, 2023 in JAMA Oncology, which is very, very pertinent to you, me, and your audience. And it's titled Vaginal Estrogen Therapy Use and Survival in Females with Breast Cancer. And it's a cohort study of almost 50,000 women, essentially showing that women who have sexual health side effects from being cancer survivors, so that's the genital urinary syndrome of menopause, is a huge issue, not talked enough about, can safely use vaginal estrogen locally for those symptoms. And per this study and many others, that will not meaningfully impact your survival, that it's safe to do that. So a lot of oncologists still feel uncomfortable with these advice, but they're pretty mainstream now. So I would say to your listeners, just to empower women to at least talk about it. And I always say, walk into your doctor's appointments with a meta-analysis printed out with the latest JAMA Oncology and just have a conversation. Doctors are good people. They are rushed, but they're good people and they want to help. And so please, everyone, look up that article. It just got published.
That's great. But you mentioned some, so maybe will you be a little bit more clear for the listeners that maybe are not in the medical field about what symptoms are you talking about?
Sure. So I'll talk about it generally, whether you're going through this at an earlier age due to cancer treatment or you're 50s, 60s, 70s, 80s, beyond. Essentially, there are estrogen receptors in the female body all through the vulva, the vagina, the urethra. So it's the genitourinary tract. And when estrogen levels drop and essentially estrogen withdraws from those receptors, there can be changes in the skin and the mucosa over time that are really uncomfortable for people. It can lead to symptoms like a urinary tract. In fact, it could lead to increased rates of urinary tract infections, and certainly pain with sex and dryness and irritation. And there's just, there's stigma. People don't want to talk about it. They might not think there's anything they can do about it. But if you really talk to people, like, it's a very big deal in their lives. If you ask them, it's a big deal. And so research like this is so wonderful because a lot of times cancer survivors can feel left out of the menopause conversation since they oftentimes would not be advised to use systemic hormones. But this is a situation where you can use a local hormone therapy. And there's other options. Obviously, talk to your doctor. Like, I'm not giving medical advice on a podcast, but where you could use local hormone therapy for one big deal symptom that really can, sexual health is sometimes it's mental health, it's relational health, it's pleasure, it's happiness. So it matters to people.
Yeah, that's very good information. And then I want to ask you another question. So you mentioned the hormone replacement. So it's so many different things in regarding hormone replacement. And again, it's not like you're going to kind of give medical advice to the audience, but in general, will you be able to extend a little bit of like, what is exactly the role of the hormone replacement? You hear people that is young and does hormone replacement because increased longevity, right? Because we want to try to avoid the wrinkle because whatever happens, and then other people does it because you're going through menopause and you want to try to, help with symptoms.
Sure. So I guess, to answer this, I would have to know if I'm talking about early menopause or sort of the average age of menopause. I would say just in general terms for people who are going through menopause at the average age, because I'm sure you have women like that listening. It is distinct if you have a cancer history or if you're 30, right? Like these are different scenarios. But in general, just in general terms, women who are going through menopause, and that means you're going to have your final menstrual period sometime between 45 and 55. And in the sort of 5 to 10 year window around that, you're going through a major transition. Just the way that puberty is not just the day you got your period, it's this series of years in your life where a lot of things are changing. Perimenopause and menopause is like that. So in general terms, what I would say to women is if you are going through menopause and you are having symptoms that are challenging for you, whether that's hot flashes, night sweats, sleep disruption, changes in your mood, changes in your thinking, sexual pelvic symptoms, etc. Certainly you want to optimize your health and take the best care that you can of yourself and eat really well, and please avoid alcohol. And all of that. But there may come to a point where you want to consider hormone therapy. And in general, if you are under the age of 60 and within that 10-year window of your last cycle and your symptoms are really significant, you may be a candidate to try it. And generally, to be a candidate, what we're looking for is, no contraindications. And you need to kind of sit and go through that list: blood clots, heart attack, stroke, hormone sensitive cancer is a contraindication. But if you're kind of a candidate, right, you're in the right age, you have the symptoms, you have the hot flashes, you don't have a reason not to take it, you can try it. You can try it safely. And, I think I sometimes joke, like, my goal is for me to go out of business. Like I want this knowledge just to be mainstream primary care. That's why I'm in medical education and work with residents, because to some extent I have to go slow in my practice because people really need to have these longer conversations, because the average knowledge is still kind of confused. People get confused.
Yep.
But I would say that it's not for everybody. You don't have to do it, but many, many people are candidates to safely try it.
Okay.
And for some people, it can be really game changer.
Yep.
Yeah.
How about patients? Because again, I get these questions asked as well. What if you have a hysterectomy or like a partial hysterectomy? And you know when your ovaries are there, so you don't really know when is your menopause. Like, how do you just go based on your looking at your hormone levels, or when do you make that decision? You go based on lab work, you go based on symptoms, do you go based what are your thoughts on that?
If for women who don't have a period, so that could be women who had their uterus removed but still have their ovaries. It could be a woman with an IUD, like a Mirena. It could be women who had an ablation. So there's a range of women who don't have a period to guide that. And if those women still have their ovaries, in fact, they're going to go through menopause like everybody else, but they wouldn't have their periods. Well, I mean, even for women who do have their periods, diagnosis of perimenopause is a clinical diagnosis. It's not that we catch a magical estrogen level in your blood and say, oh, it's actually not that confusing. It's, you're 47 and you're having hot flashes. And even if we don't have the bleeding to guide us, like irregular periods, we rule out other things, make sure there's no thyroid disease, make sure you're not having some autoimmune or something new, we can diagnose in the absence of the period. Now, in terms of knowing when you're officially postmenopausal, right, that line in the sand, which I just want to say for many women, like their lived experience is knowing when they cross the line doesn't really change anything from one day to the next. They say, okay, I've got a year without a period. Now I'm postmenopausal. You wouldn't have that line. But that line is most important for your medical care than anything else, because what we want all women to know is that if you're postmenopausal and then you started bleeding, you got to see your doctor. Gotcha. So, it's valuable to know, like, ring the bell, hooray, I crossed the line. But in reality, this is sort of a 5-10 year period transition of your life. And so whether it's last month or this month, it matters most to that postmenopausal bleeding workup.
I got you. Perfect. That's very good. I think that will be clarified because, some people ask me that, like some people ask me, well, if I'm hormone positive for cancer, breast cancer, and I had a hysterectomy already. Why do they want to give me hormone blockers, right? So that's another question I get often.
But they still have their ovaries, maybe, or no, they don't.
Even if they didn't. But so it's like, I don't have my ovaries. I had a full hysterectomy, but I'm hormone positive on breast cancer. Why should I take these hormone blockers? Right. Sometimes, so I kind of, as learning, kind of talking to other physicians and things like that, it's like, well, hormones not only come from your, ovaries.
True. Yeah, that's true. It's such, just hearing these questions and knowing that women have these questions and they're asking you because they trust you,
Yep.
it makes me think two things. One, it makes me realize how important it is that everybody on the healthcare team be educated about things like menopause, whether you're a psychotherapist or a physical therapist. Like, we need people to know stuff because you're going to be asked because you're trusted. So that's the first thing that comes to mind. But the second is how vulnerable cancer survivors are, and how specialized their care needs to be moving forward. And I think one niche that I would not claim as my niche right now, but I would love to get a colleague perhaps that could do this, is cancer survivorship care, like really thoughtful consults to answer all the questions, tell you what's safe. Because what happens is once you're done being treated, this magical team sort of signs off.
That's exactly right.
And I think cancer survivors feel very alone. And then they go to their regular primary care doctor, who I am not blaming, like that is me too, who it's hard to keep up with cancer care and know all the latest stuff. So I hope to see in the future, just like my clinic is sort of a niche primary care model, a niche primary care just for cancer survivors, screenings and, specific symptoms and how to help you and who's the best to do this. And in any case, I feel for these women because they're often alone.
Yes. And I haven't released her yet, but is Dr. Commander is a medical oncologist over General Massachusetts, and they have a survivorship program, which I told her, I said, will you please come over here and let us copy your program, because it's survivorship. And you're right. So this is exactly where I have the fortune to have breast cancer patients and follow them up to 5 years. To just kind of make sure that, they're not developing lymphedema, so we can, get those symptoms early and reverse it versus having to deal with that, but as well looking at other things. So yes, so they trust us and ask us all these questions because they don't see the physician anymore, right? Or they just see them once a year. And then in the meantime, they're dealing with all these symptoms that they're like, well, I have joint pain everywhere, I'm miserable, but I guess I have to take these hormone blockers because otherwise my cancer comes back. And I'm the one who has to tell them, it's like, no, really, I want you to reach out to your medical oncologist and tell them that you're miserable and what other options you have, because there's other options out there.
It's such an unmet need. And hearing you talk about this, it's such an important reminder. That Boston clinic that you mentioned, is that housed in their oncology department, or is it housed in primary care?
No, it is housed in oncology department. Yeah.
Well, that's wonderful that they take that on. And I'll definitely look at their stuff. It's an important field.
Yes. And I'll be happy to send you their, I believe I don't remember, it's like, it starts with a P and I don't have it on top of my head. I'll send you the info. But it is great. I was like, they have nurse practitioners. It's like great. So they have all this education on nutrition and exercise, and really what you're saying, a lot of these patients, not just breast cancer, but this program is just for breast cancer, but in general, any cancer survivor, yes, you just kind of finish up your journey and then you're like, okay, great, I'm done. And now who I do go see when I have these symptoms? Who do I contact?
There's nobody, it's nobody's job right now.
I know.
There's no doctor whose job, it's primary care, but that's hard, and it's gynecology, and that's hard. But unfortunately, your cancer team, if you're in remission, I mean, there's not a lot of active management going on.
Yeah, right? Exactly. So hopefully we can see some changes with that.
Yeah, we'll work locally.
Yeah. So is any 3 tips that you can give to this audience from your journey working just as a primary care physician and kind of like focusing where you're focusing on the menopause part? Just in general, if you have 3 things that you can give to them, what would that be?
Well, that's a tricky question because I don't know if we're looking for general life advice or something
Yes,
else.
absolutely. Yeah, no,
Okay.
yeah, absolutely.
Yeah.
Anything that come to your mind that you feel
Things
like,
I think if I look back at my journey or, how I move through things, one thing I would advise, and this is my perspective, but is to pay attention to timing. Pay attention to timing in whatever that means to you. So it could mean, when things happen, coincidences back to back, something lands in your lap, these things, I really pay attention and I let that guide me. Sometimes I might say yes to something that I would otherwise say no to just because the timing of when it arrived is so compelling to me that I can't ignore that. So that's a tip. I live by it. It may not work for everybody, but I say try it out.
okay, perfect.
Let's see what else. For the medical field, for people in the medical field, I wish I had a tip. I know not everybody can do exactly what I'm doing, which is kind of take these risks and start this practice, but I just want doctors, and I know it's not just doctors, but that's who I think about a lot. To really understand their value. Healthcare is changing so quickly right now, and I'm not afraid of that. I'm embrace the future, and the future has AI and has a lot of things in it. And I think doctors really need to dig deep, and we need to ask ourselves, where is my value? And where you find that, that's what you need to be spending your time on. And I think it's often in this relational care. And I don't know how we all are going to get there collectively, but if you could do it, even in small ways, to like claim your time, claim your value, because I think our profession is actually at stake. Yeah. If we don't, it's being degraded right now. Yeah. So that's for doctors. And I got to come up with one more tip. This one's a total cliche, but sometimes cliches, they hit you and you're like, okay.
Yeah.
And this was one in a previous job. I had this light bulb moment where I was like, nobody's going to save me. No one's going to come one day and say, hey, Lisa, I see that you want to change and here's your change. And I think that message is especially important for women because we are conditioned to hope and pray for Prince Charming, for something outside of us to come and make it safe and good and easy. But when you lose that illusion, you feel super free and you're like, I think I'm going to do something else. Like you're not waiting. So those would be my 3 tips.
That's very good. I like that. That's very good. So that has been super fun. Thank you so much for taking your time out of your busy schedule to do this with me. I'm sure that you'll get some phone calls because, I'm from people that I'm going to say, I already have heard great things about you through some of our pelvic health team here at UF. So
we should recognize them because that's who introduced us, right? I was invited to give a talk to the pelvic floor physical therapists at Magnolia Park, and then one of them referred me to you. So we should acknowledge them. And Darlie, I'm going to be reaching out for clinical stuff. So we'll collaborate for patient care, which is what it's all about.
Absolutely. Anytime. And thank you again so much for doing this with me.
Of course. Thank you.
Okay. Have a great evening. Bye.
Bye.